Welcome, everyone. Very excited to have you joining us for our collaborative care series. This is a special case study on heart disease and looking at heart disease from a collaborative and interprofessional approach. Very excited to have you all joining us today. Want to begin with a land acknowledgement, and I want to invite you to join me in the chat by acknowledging the Indigenous name of where you are located. The website placenames.mapdev.ca is a good website to help us in the how to pronounce, how to spell, how to know the specific village or town where you are joining us from. And as you are joining me in the land acknowledgement and acknowledging where you are located, I invite you to take this moment to think about gratitude for what you love. So for example, I am speaking with you from Unama'ki. Unama'ki, sometimes known as the land of fog, is what it means in the Mi'kmaq language. And the fog lifting from the water is something that I don't think I ever appreciated was beautiful until I moved here. And that's one of the many things that I really love about where I am here in Unama'ki and for which I'm really grateful. So as I am reading the land acknowledgement, I invite you to join me in the chat, not only by saying the Indigenous name, but also by reflecting on that which you are grateful for where you are located. And I acknowledge that where I am is located on the ancestral and unceded territory of the Mi'kmaq, whose inherent rights were recognized in the peace and friendship treaties that were signed with the Mi'kmaq, Maliseet, and Passamaquoddy peoples from 1725 to 1779. This series of treaties did not surrender Indigenous land, resources, or sovereignty to the British Empire, but instead established rules for an ongoing relationship between nations. The treaties were later reaffirmed by Canada in Section 35 of the Constitution Act in 1982. They remain active to this day. So we take this time to pause in reflection and gratitude for the land where we live and work. And when we acknowledge the land, we seek to also acknowledge the wisdom of this planet and align ourselves with its truths. And so as we pause in gratitude, we also are grateful for all who have and continue to heroically care and advocate for this beautiful land. May we join them in this sacred work. Let us ground ourselves in the wisdom of the land-based Mi'kmaq teachings and values that we must all begin to learn. Let us work to decolonize ourselves, our practice, and this community that we share, by working for justice for all living beings as an expression of our gratitude for being here. Let us take a deep breath and recenter ourselves away from the violent ways colonization fills our world and fills us. Let us take a deep breath and work on letting go of the unconscious bias that is everywhere, inside and out. May our session today lead us to be in right relationship with this land and with one another. We are all treaty people, so how does this impact what we do and how we do it? And how will it guide our work together today? For us, the Nova Scotia College of Social Workers commits to translating this acknowledgement into action by seeking to implement the recommendations of the Truth and Reconciliation Commission's calls to action. We commit to doing what we can to becoming better treaty partners. We commit to learning and to unlearning. Decolonizing ourselves in our practice means recognizing the ways in which we are each impacted by the colonial system in which we all participate, and from which those of us of settler descent continue to benefit. Each of us, depending upon our social location and intersectional positionality, are uniquely impacted or oppressed. For example, those of us from African descent were dispossessed and uprooted from their land and brought to Turtle Island against their will as part of the white supremacy and slave trade that fueled the settlement of this continent. We take this moment to reflect upon the unique impact of colonization upon each of us and upon our practice. We also recognize that becoming anti-racist is a journey. And it goes from not recognizing that the problem exists to avoiding or being uncomfortable because we are in a place of fear. And that learning also involves unlearning as we work towards safer care. And we say safer care because we recognize that safety is not necessarily something we can ever begin to fully understand at this point of where we are in our systems. So there's a lot more that we can begin to do before we get to the other end of this visual, the green arrow that's pointing to this place that we can't yet even fully imagine, given that we live in a world that does have so much racism and intersectional bias. The Canadian Association of Social Workers' new code of ethics requires us to shift from the illusion of neutrality to becoming actively anti-racist and fighting against racism and all intersectional prejudice that is part of colonization. Now, social work understands public health and safety as including the psychosocial, spiritual, structural, and ecological determinants of health. And so, as we think about ethical and safer care, we recognize the influence of intersectional bias and racism and colonization on every single aspect of us and on every single level of the system. In social work, we talk about three different areas, not that they're separate, but that they speak to different perspectives. So we often think of social work in terms of the micro work, which is to say working with the individual and perhaps their families. And we would work with them from a healthcare perspective in terms of housing, healthcare, social services, trying to treat a variety of different issues, primarily mental, physical, mental, behavioral, or emotional. But we recognize that individuals are part of larger systems. So the mezzo system or the meso system is speaks to the ways in which social work tries to recognize the influence of groups and organizations such as schools, businesses, neighborhoods, hospitals, nonprofits, other different kinds of community organizations, communities of faith, and all of these have influence on a person. It will influence their well-being. And when we work with individuals, for example, in a hospital or in a healthcare environment, one of the things that we try to do is help connect them to the larger systems and organizations that can help connect and ensure that health and well-being. We want to connect individuals to groups, recognizing that simply, for example, working with someone, other people can be itself beneficial. But we also recognize that there are macro level systemic influences. And so there's also a macro social work practice, which is focused on laws and policies and advocacy and ways of shaping social policy, recognizing that a lot of those social policies and dominant ideologies and the economic infrastructure all influence, that larger structure influences the work that we do. And then there's the ecological broader influence as well, the ways in which we're connected to the earth and the land and all of that as well. So because social work understands each individual and there's multiple different approaches to social work, and just even the word social work has that, we do have a different approach to mental health. We have a questioning of understanding around the pathology of it, because, for example, if somebody presents with depression or anxiety to their provider, and let's say that the issue is because they are burnt out because they are working for a job that is under-resourced, and so they are maybe doing 2 or 3 jobs at once, and perhaps they are dealing with racism or microaggressions, and they can't leave their job because of the housing crisis and the cost of living. They might be depressed and anxious. And actually, that's a normal and appropriate reaction to a context where there's so many structural injustices and problems. And so if a social worker is working with someone who is dealing with that, and they may have on top of it their own intergenerational trauma or traumas related to early childhood adverse experiences, all of that can kind of like co-interact and overlap and intersect and influence itself. And so when social work is practiced, we try to look at the larger system. If, for example, I work with them on cognitive behavioral therapy to help someone do some behavioral activation, for example, go for a walk or do a meditation or do a deep breathing or help address maybe a cognitive issue like either or thinking, which is actually a binary colonial construct. That might help. I might help through a counseling or some kind of psychotherapeutic intervention. I might be able to help the individual cope or sleep with the stress on a given day, but it's not going to address the larger structural issue. If, however, I connect that person through advocacy or to a social, let's say, why don't you join this organization that's working to raise understanding around racism or that's working to address the housing crisis, then that social justice organization can actually be a therapeutic intervention because that person is then part of a larger group. They're part of solving the problems, not just feeling depressed and anxious and hopeless as an individual, but they are recognizing that part of why they're depressed and anxious isn't their fault. It's part of the larger whole. It's part of how they're perhaps being experienced. So when we connect people to the larger whole, that is part of our vision and understanding of how we bring healing from a social work perspective. So even, for example, I'm going to write my MLA and I'm going to talk about my concerns around racism, or I'm going to talk about my concerns around the housing crisis. I'm going to share my ideas. That can actually be a therapeutic intervention. And so we've been working on creating guidelines for advocacy and how to integrate that into our healing care plans for ourselves and for the people we work with, recognizing that if individuals exist within larger wholes, then healing must happen on multiple different levels. And that, of course, is part of the vision for our interprofessional series today, in part because we understand that safer patient care happens when we see the whole picture, and social work has a unique lens, but every healthcare provider has their own unique lens. And so we're really excited that we can be working together because we believe that when the patient has access to multiple different clinical perspectives, multiple different professional perspectives, then that ensures safer care because more people understand all of the different components and can figure out how to best support individuals. So that is actually the vision for why we are so excited and grateful to partner with our other what's called allied health professions in this new interprofessional education and collaborative care series, which is jointly organized and sponsored by the Association of Psychologists of Nova Scotia, the Canadian Association for Spiritual Care, the Nova Scotia Physiotherapy Association, Nova Scotia Society of Occupational Therapists, and the Nova Scotia Therapeutic Recreation Association. Today is the second of a four-part interprofessional panel series. In August, we will have one on assessments and how do we, as healthcare professionals, recognize what other health professions might need to be involved in the care. How do we assess? How do we advocate for each other? And then in October, we're going to be talking about what does decolonizing our care look like, each of us from different professions. We also have different lunch hour, just grab your lunch and mingle, network, get to know other healthcare professionals from multiple different professional disciplines, getting to know each other and talking about self-care and how do we address burnout. Of course, we're burning out if one or two professions are trying to do 12 different things And, you know, if there isn't a social worker, or there isn't a chaplain, or there isn't an occupational therapist, or there isn't a physical therapist, or there isn't a recreation therapist, then the doctor and nurse are left having to do all of those different things simultaneously, plus their own job and profession. And they're not trained to be a social worker or chaplain or a recreation therapist, right? So they don't have that lens. So by advocating for an interprofessional approach, we are not only advocating for safer care for patients, but also for every single healthcare professional that would be less burnt out if they weren't trying to do the job of multiple other professions. But if there are other professions that are integrated more comprehensively into every aspect of care, then that can really make a difference. And so we're looking at cardiac care because right now there's this belief that there's a mind-body split and that we don't see as standard care for heart attack or heart disease all of our other disciplines. And yet that's partially because we're not talking about the ways in which our emotions are connected to our bodies, the ways in which the heart actually can be influenced by emotions, for example. So because there is growing understanding in the scientific world around the mind, body, heart, spirit connection and the larger social connections. So there's ample research that shows this interconnection. However, our current organization of our healthcare system does not yet have a full integration of all of the professions and disciplines that can support the actual healing that needs to be done because it's primarily focused on a biomedical pharmaceutical model only. So when we think about heart disease, we don't think about heartbreak necessarily, for example. But actually, research shows that a broken heart is not just folklore, but actually, usually there are other issues that sometimes can affect the heart because of grief, which can or trauma or fear. It can stimulate the adrenal glands, the nerves that will affect the way we have our heart functions. So we are part of this series is to revisit our understanding of the mind-body connection. And collaborative care is about safer care because it's about whole person care that recognizes its larger context. And heartbreak, for example, is one example. So you can see here the ways in which the actual heart is affected by despair, by sadness, the respiratory system, the digestive system, the immune system, the endocrine system, the brain, all is affected by the emotions. So that's where if there's more of an integration of mental health and spiritual care and recreation therapy and occupational therapy and all of these different components are part of standard care for heart disease, then how can we be looking at that differently? In fact, there's a lot of research that shows that heart disease in general is 100% related, that anxiety, depression both cause because of the stress, but it also is a consequence of heart disease as well. Now, we may know about adverse childhood experiences, that people who experience adverse childhood experiences are at a much higher risk for heart disease, death, and a variety of other health problems later in life. And so we do know from a research perspective that there are cardiovascular changes as a result of adverse childhood experiences that will also affect social outcomes, economic outcomes. There's a multiple different reactions as a result of that. But we also are starting to understand that after a heart attack, the heart stops pumping to the brain in the same way, and then the brain chemistry is affected. So it's actually standard care. It's actually standard for, according to research, when someone has a heart attack, that they're going to be anxious and depressed. but we don't say that to people. So they might not even know or understand that that's why they're anxious and depressed, separate from the trauma that comes from a heart disease. And so when we think about care after the heart attack, for example, as a case study, it would be from a social work perspective good to educate, to inform the patient about this, and to make sure that they have some structural reinforcement, that they are connected as part of their discharge plan to a support group, for example, or to community organizations that can help them feel less alone or isolated, that they can have some of that reinforcement for some of the other psychosocial structural stressors that perhaps were pre-existing and might become more stressful following their cardiac event. The truth is that we don't fully understand yet, but there's a growing research that shows that, but our healthcare systems are not reflected in the way we do that. In fact, when we say, for example, oh, you have to watch your diet, well, a focus on diet without a focus on the larger structural issues can actually, from a social work or trauma-informed perspective, it can backfire because it can make that person blame themselves. Oh, it's my fault, instead of understanding the larger structural pieces. And if we think it's my fault, I should be eating more carrots, I should be exercising more, then that blame can actually make things worse because we feel more depressed. We are feeling more ashamed, like it's all our fault, without thinking maybe I don't feel safe to walk outside of my apartment. So telling me I need to exercise if I can't afford to go to the gym, and I don't feel safe walking outside of my neighborhood because maybe I'm going to be, for whatever reason, or I can't afford to buy carrots because of poverty or structural justice issues, then that actually contributes to more hopelessness. So having that prescription without looking at that larger whole is one issue. Thinking about how eating as has cultural factors, how body and weight bias can actually sometimes cause more harm. These are some larger issues. So for example, research actually shows that people have significant other concerns around their health that are not necessarily always seen. So that is one of the reasons why we are advocating for a larger holistic vision. And we're grateful to have the lenses of other professions who are going to come and share a little bit of their understanding around heart attack, heart disease, what needs to be involved, so that we can begin to advocate for each other and have a more comprehensive understanding of illness. Sorry, this is from, we had Social Work Month, we were giving those books away. You might be interested in those books. They are great books, especially Decolonizing Therapy and Rest is Resistance, Recognizing the Role of Rest. So now we're going to have a chance to hear from Paige, who's going to be speaking a little bit now from the perspective of occupational therapy. And so welcome.
Thank you, Naj. Hello, everyone. My name is Paige, and I'm an occupational therapist at the Halifax Infirmary. I currently work within the medicine and surgery program, and I've spent the past 2 years working in both cardiology and cardiac surgery. So today I will be sharing my perspective on cardiovascular care from an OT lens. So my role as an OT in acute care is to work collaboratively with clients, their families, and interdisciplinary team members to facilitate, restore, and maintain a client's optimal level of function, and more specifically in the areas of productivity, self-care, and leisure. In a cardiovascular context, I typically administer assessments, provide interventions, and make recommendations and referrals to additional services. So for example, that could be referring to a restorative care unit, cardiac rehab, community or outpatient occupational therapy, and many more. My role as an OT in the cardiac surgery ICU is to establish a client's functional baseline following surgery. So what were they doing before they came in? How were they managing with their everyday activities before they were admitted to hospital? I then assess overall function. So take a look at how they're currently doing with their functional transfers. How are they getting in and out of bed? Can they get on and off the toilet? I'm looking at how are they doing with dressing, bathing, and grooming tasks. There are many post-op complications or complex hospital stays that have a significant impact on a client's level of function. So some common post-op complications I typically see are post-op strokes, prolonged intubation, or difficulty coming off of a ventilator, which then leads to further deconditioning and a decrease in overall function. A large consideration following surgery are sternal precautions. So cardiac surgery can be very invasive, and anyone who has had a sternotomy must follow sternal precautions, meaning they can't push or pull more than 10 pounds with their arms for 6 to 8 weeks post-surgery. Sternal precautions are critical post-op to protect clients' sternums and allow for proper wound healing at their incision sites. I've unfortunately seen many clients be readmitted to hospital with sternal wound infections as a result of not following these precautions and not allowing their sternum to heal properly. And so, as you can imagine, sternal precautions significantly impact an individual's ability to participate in their everyday activities. Often people have to learn new ways to engage in activities that they've done the same way every day for their whole lives. And so there is a very strong need for support, and whether that's formal support from continuing care or private services or informal supports from friends and family, there is a strong need for support upon discharge to help with engagement in everyday activities. So it's very difficult to vacuum, clean, do laundry, and many people aren't able to drive while they are on sternal precautions. So as you can imagine, that has a huge impact on people's lives. The inability to engage in these occupations has a significant impact on someone's discharge. And so these are all things that are taken into consideration when engaging in activities and recommending equipment. So for example, I do not recommend a bed rail for people who have sternal precautions because pulling yourself up can be damaging to your sternum. Same thing with not using a grab bar to help yourself get up off the toilet. When it comes to wheelchair seating and mobility, we have to learn how to foot propel a wheelchair instead of using hand propulsion to improve your functional mobility. So all of these are things that need to be taken into consideration. And then when a client is medically stable and they're able to safely engage in their everyday activities and have the supports that they need to return home, they are discharged from the hospital. And when 6 to 8 weeks has passed and they are medically cleared by a medical professional, then that client becomes appropriate for a cardiac rehab program. And so overall, that is a very quick snapshot of what my role is as an OT in cardiovascular care. And lastly, I just wanted to touch on a few points regarding what I think is missing in our current biomedical model. So currently, there is no occupational therapist position within cardiac rehab. And I believe that there is absolutely a role for OT in this setting. So having that follow up with an occupational therapist, being able to further recommend equipment, help people who are transitioning back into their everyday activities. So I think that would be very beneficial thinking into the future if we could eventually gain a position with cardiac rehab. And lastly, something that I think is missing from our current model is the lack of psychosocial support. So currently where I work, we have one psychologist for the entire hospital. And having surgery can have a huge impact on your mental health. There's great stress and anxiety that comes with thinking about having surgery and then going through having surgery and learning how to trust your body again after having a significant cardiovascular event. So I think an increase in positions for not only psychologists, but for further positions for spiritual care and social work are greatly needed. And that is all from me. So thank you, Naj, and thank you to the Nova Scotia College of Social Workers for having me. And thank you everyone for listening.
Thank you so very much. Very grateful to you. And now we are going to have a chance to hear from Elizabeth. who is going to speak to us from the physiotherapy perspective.
Hi there, everybody. Again, thanks for having me. I'm just going to get my PowerPoint up here. Start there. So my name's Elizabeth. I'm a physiotherapist, and I work with NSHA as well in the Hearts and Health and Motion program. I do have a little bit of a background in acute care before I came over to cardiac rehab, and I've worked casually as well in the Halifax Infirmary and some of the different units there with Paige. I won't say I have a great understanding of the cardiac unit specifically because I didn't spend a lot of time there, but I do have a little bit of experience there. So I'm just going to briefly touch on kind of what the physiotherapist role is in that first acute phase, and then I'll talk a lot more about the cardiac rehab perspective. So what we call phase 1 of cardiac rehab is really that acute care component, where the patient's either in the ICU, IMCU, or maybe they're on some of the floors. And really the role here of the physiotherapist is help promote a safe discharge home, so patients can go back home and continue their healing. So there's a big focus on safe mobilization with monitoring for those signs and symptoms of overexertion while mobilizing. So looking for shortness of breath, looking at their heart rate, looking at all those different things. Respecting sternal precautions for sternotomies, as Paige talked about earlier. Anybody who's had like an open heart type surgery, they are on those sternal precautions for 6 to 8 weeks, which is going to impact their mobility. Prescription of any gait aids as needed, and often stairs assessments as well are a really important component to people going home safely. There is some focus on some airway clearance techniques, especially for patients with sternotomies. As you can imagine, that's going to impact their breathing and their ability to cough and clear secretions from their lungs. There's a big education component as well prior to discharge, covering things like safe exercise, reviewing the sternal precautions with patients and giving them some exercises they can do at home, as well as the physiotherapist is going to be involved in that discharge planning as part of that multidisciplinary team. And then after they get discharged from the hospital, that's when they come to us. So I work with the program in Central Zone. So we have sites in Halifax, Dartmouth, and Lower Sackville that our team works at, but there are some sites throughout the province as well. So this is our program here in Halifax. So we do a 12-week outpatient exercise and education-based program. And we do have a multidisciplinary team, which I'll talk a little bit more about later. And it really is part of that continuum of care. So once the patient gets discharged from the hospital, then the referrals come to us. So we basically see anybody who's had any sort of cardiac disease, but our main population is going to be these three. So medically stable patients post MI, stable angina or CABG or an open heart bypass type surgery. We also see patients with heart failure, heart transplant, valve surgeries, peripheral artery disease. And then we also see patients with what we call primary prevention. So really, we're split into kind of primary and secondary prevention. Secondary prevention being those people with established coronary artery disease, peripheral artery disease, or cerebrovascular disease. And those primary preventions are those people who have risk factors for coronary artery disease. So it's going to be diabetes, hypertension, dyslipidemia, all those sorts of things. And yeah, like I said, we see many different types of people with many different cardiac and vascular diseases. So, like I said earlier, after the patient gets discharged from the hospital, the referrals come to us. So we actually have an automatic referral system to make sure that people don't get missed in the referral process. So anybody that's discharged from any of the cardiac units or the cath lab at the QE2, all of their referrals come to us automatically. We also take referrals from other healthcare professionals, and that can be anybody. That can be a physiotherapist, a dietitian, a family doctor, nurse practitioner, registered nurse, social worker. Anybody can send a referral. And then our RN team here triages the referrals to make sure that they're appropriate for the program. So our core team is composed of a physiotherapist, registered nurse, and dietitian, and each program has those assigned to them. In addition, we have a medical director who's a cardiologist as part of the program, as well as we have a nurse practitioner, which is a new role for us. which I'll talk a little bit more about later. Our team does not yet have a psychologist. We do have a new position that has been posted and filled, but the person's just on parental leave right now, so they're going to be starting in the summer, and we're really excited about that. The team in Sydney also has a psychologist. I'm not quite sure if they have a social worker yet or if the posting was going up for a social worker, and they do also have a pharmacist down there as well. So like I said, we are an exercise and education-based program. You can see one of our nurses there on the left chatting with a patient on the treadmill, and we have our dietitian on the right here going over some education. So the patients come in groups. They do the exercise as a group, and really the physio's role in our program is to lead the exercise class with the nurse and dietitian there to support. And then we do all kinds of different education topics throughout the 12 weeks. So they're going to touch on nutrition. The physio talks about exercise safety and exercise guidelines. Nurses are teaching about medications. We also talk about stress. We talk about risk factors, including like smoking cessation and all those different components. And everything we do is really guideline based. So you can see the 24-hour movement guidelines on the left, Canada's food guide on the right. And we have started this new program called Reduce It, and we're really looking at standardizing cardiac rehab care across the province. It's not that we're doing anything new or exciting besides the guideline-directed medical therapy, which I'll talk a little bit about. It's really that we want to make sure that all patients across Nova Scotia are getting the same standard of care, whether you live in Sydney, Halifax, Yarmouth, wherever it might be. The guideline-directed medical therapy is the only real new component added to our program, and we're really excited about that because our nurse practitioner can adjust patients' medications right on site, order blood work and different tests to make sure that they get that care that they need, which is really important because we're seeing so many people without family doctors as well. So having access to that's really great. And again, this is just kind of an overview of what we're doing in Reduce It. We have our team assessment. We're still managing our risk factors and doing our supervised exercise. And number 4 is really the new component to that for us. So why do people come to cardiac rehab? We're really looking at those modifiable risk factors and kind of meeting the patient where they're at to see what kind of changes we can make, because really our end goal is to help prevent future hospitalizations, future cardiac events, and future emergency room visits. So a lot of what we do is based on behavior change. So while our education and exercise components are group activities, we do have a lot of one-on-one time with the patients as well while they're in the gym exercising, or maybe we follow up with them on the phone afterwards, those different types of things, to help patients establish their goals and see what we can focus on and help like kind of meet them where they're at to achieve those goals. So for our outcome measures for the program, we do often focus on a lot of those biological or biomedical model type outcome measures. So this is the report that gets sent to the family doctor once they're done. We're really looking at a lot of those numbers for exercise, lipids, blood glucose, blood pressure, all of that. But we also collect some information from the patients at the beginning and end of the program with some questionnaires. And again, this is a lot of its data. We have a very large database that we collect a lot of information on, but it also serves as a screening tool. So for example, as a physiotherapist, I'm often looking at the CSEP score to see what our patients are doing for exercise and how I can work with them to make changes. The dietitian are looking at the dietary scores, and the nurses are really looking at that satisfaction with life scale and the quality of life ladder, which I highlighted here and added on the right side. And we can always, help the patient if they're interested to find some help if they need it. So often we're referring to the AP&S website to find a psychologist if they have if they're lucky enough to have private insurance, and or we're referring through the NSHA mental health and addictions programs as needed as well. And this is really just a screening tool to flag that for the nurses to have that conversation. And the research regarding exercise-based cardiac rehab shows that it is reducing hospital admissions. It helps reduce anxiety and depression, reduces mortality, and it helps improve those health-related quality of life, helps improve physical activity status and exercise capacity. So as I said, we do have a psychologist being added to our team this summer. I believe the psychologist in Sydney works with the team as kind of a consult basis as needed. We've identified a need for a social worker, and I think that's a new role coming to the Sydney team, and we would love to have one in our Halifax team as well. And we're really looking, like I said earlier, about standardizing that care across the province. So that's come with some funding for some of these new positions, which is great. And looking what the future research says as well. So we, like I said, we're collecting a lot of different information for that database. And we also have a new project coming as well for some more expanded virtual programming. We do have virtual programming in the Central Zone, but we're really looking at targeting some of those traditionally underserved areas and including the whole province in that virtual program as well with the Reduce It. Okay, and that's all I have there for my presentation.
Thank
Are
you.
there any
So
questions here?
there are, you can look at it in the chat. We will have a chance
Yeah.
for questions at the very end as
Okay.
well. Thank you so very much. And we are now going to get a chance to hear from Kirsten from a clinical spiritual care perspective.
Hello. Thank you very much, Naj, and thank you to my co-panelists and everybody here. My name is Kirsten Wells. I have worked as an inpatient acute care spiritual care clinician at Nova Scotia Health since 2005 and elsewhere before that. And currently I am working with the Inspired COPD community health team, and my role is spiritual care and advanced care planning. I prepared some notes, so I'm going to try and stick to them. Otherwise, I will talk way too long. So I welcome any questions in our conversation after the panel. So here are my reflections on heart attack and cardiovascular disease treatment, a spiritual care approach. While I was thinking about this, I thought there's a real difference between the ideal treatment plan and what actually happens. So I'm going to go back and forth a bit between those two things. Ideally, every person in the cardiac program would be assessed by a spiritual care specialist to determine the psychospiritual effects of the cardiac event on the person and their interest in incorporating spiritual care into their healthcare and recovery. It is not unusual for spiritual care to be consulted in death and dying scenarios in cardiac care. In that case, the role is confined to assisting the patient and family navigate the death experience and medical interventions or the removal of interventions before the death occurs. Spiritual care clinicians are trained in crisis intervention and to work to stabilize and support the patient, family, as well as healthcare staff in the midst of a crisis. Clinicians take direction from both the team and the family in terms of what needs need to be addressed first. When direction can't be offered due to the trauma and chaos of the situation, clinicians assume a leadership role by presence, responsiveness, and navigation of the current situation. We focus on basic needs and non-abandonment. For example, we could be asked to provide religious care. This is quite common for certain patients who belong to specific religious groups. Roman Catholic Christians spring to mind, have a very specific religious care routine at the end of life. For others, it can involve sitting with the family, waiting for information, and debriefing events from the crisis. It can involve the clinician witnessing treatments like CPR or other emergency ICU interventions, and then communicating with the family about what is happening to their loved one. And it also involves debriefing follow-up after the crisis has passed. The crisis intervention scenario goes more smoothly when the patient and family are known to the clinician. So now we're going back to the ideal. In that way, the support ritual and as well as general communications are much more fluid and less stressful overall. However, as we all know, the ideal is not always possible. so we do the best we can. Subsequent interactions may involve assessment and treatment conversations with the patient and the family, and a collaboratively decided upon treatment plan, the results of which are in the hands of the patient and how they choose to use their resources and energy. We also regularly refer to community care upon discharge from hospital. After deaths, spiritual care provides support to the family emotionally and practically with such issues as how to contact a funeral home, organ donation, autopsy information, and concluding communications and goodbyes with the healthcare team. Clinicians also work with the Office of the Public Trustee if they are involved as a delegate decision maker or when they become involved when no one claims a person's body. Back to the ideal scenario, patients would be triaged based on collaborative assessment process between clinician, patient, and team. And it's interesting, I've observed that there are very different perceptions of who needs care and when, based on who you ask, the team, the patient, or the clinician providing care. The clinician follows the patient from unit to unit in the cardiology flow. So for example, if I encountered a patient in Emerge, I would follow that patient through the various units and stages of treatment in the hospital to discharge. This continuity of relationship and accompaniment through the levels of treatment are components of gold standard spiritual care. And patients report very high levels of satisfaction with this approach because it helps create a relationship of trust and continuity throughout their treatment. In this role, it's not uncommon for the spiritual care clinician to be communicating a lot of patient history to the new treatment units as the patient moves through the healthcare facility. The nature of the information is psychosocial spiritual, so contextualizing them in life, their identity, their state of mind, and their beliefs and values. Areas of assessment include overall emotional and spiritual state in reaction to the heart event, reviewing the life circumstances leading up to the event and the ramifications for the future, looking at what or who helped them through hard times and how well those resources are supporting them in the present. Faith and religious group of origin and participation, history and current practice are explored, and what beliefs the patient holds about why this happened to them and what is likely to happen next. What we listen for in our assessments is spiritual distress. We also listen for sources of positive coping and development, personal practices that support health and wellness that can be supported or enhanced during hospitalization, connection with religious leaders, religious communities and rights or other groups that function similarly, and any effects of the person's beliefs and values from a spiritual perspective on the healthcare treatment that they are receiving. And we assist the patient in communicating these things to the healthcare team in a very medically based model. A care plan is developed based on identified issues needing support and mutually agreed on by patient and clinician. So spiritual distress and cardiology themes. What I have noticed over years of practice are the common emotional reactions of vulnerability, guilt and shame over past actions, common feelings of emasculation for men, or confronting needs to be given care versus providing it, which tends to be more a woman's experience, but those are not exclusive categories. Autonomy and independence seem to be shaken, resulting in fear and trauma about the next heart attack, about trusting one's body, about one's ability to function in the world. And there's a lot of emotional lability. And thank you, Naj, for the thorough introduction about heartbrokenness and the connection between feelings and our health. This is the focus of spiritual care interventions generally, and in particular in cardiac care. People experience a great lack of containment, identity shifts, regret, grief, and the ultimate reckoning with death. And this can look like death education and coaching. It can look like near-death experience debriefing, and also advanced care planning for future healthcare at the end of life. This is what I have for you in my official notes, and I made a couple of notes while other people were talking. Let me just have a look here. Yes, I wanted to just mention compassion. I think compassion is deeply rooted in the practice of spiritual care, and I have noticed over the years that cardiac patients often have a really hard time giving themselves compassion. So compassion comes up a lot in this kind of experience, and the healing that we try to help patients achieve after their heart attack. And I'm talking not only the physical healing, but the emotional and spiritual healing of having an event that forces a look, forces some self-awareness, some integration of things that have been left disintegrated previously. So we see a lot of talk about relationships, marital issues and conflicts, work-life balance, self-awareness, and a lot of dealing with previous grief and loss issues, which would speak to the heartbreak. And I did want to also mention, not people often think that spiritual care is only for religious people. And that's not a silly thing to think, because for quite some time, spirituality and religion were the same thing. And so it's confusing. So I would like to say, when a spiritual care clinician encounters a patient, we let them define what spiritual and religious mean to them. And then we work within their system of belief and understanding. So we get pretty creative. Doing religious rites, that's simple. There's a book for everything. We can call someone if we can't do it ourselves. But for other people who I would say are the majority of people, even religious people, ritual is a very important way of marking an event, understanding what's happened, and processing these feelings non-verbally as well as verbally. And that can look like a lot of things. It can look like art, it can look like music, it can look like the sky's the limit, pottery. Wow, I've done a lot of creative things over the years with patients to help process the feelings. And I define all of that as inherently spiritual processing. So thank you to my colleagues. My brain is whirring with everything that you shared so far, and I look forward to the conversation after. Thank you.
Thank you so very much. And last but definitely not least is Dawn, who's going to be speaking from the perspective of recreation therapy.
Sure. Thank you, Naj, and thank you, everyone. I'm glad I went last, because I was learning as I go. In most settings, I could think of someone off the top of my head who would be an expert in that area in terms of recreation therapy and stroke, mental health, and addictions. Cardiovascular health, not so much. We currently don't have any recreation therapists that I'm aware of, and it is a small province, in cardiac rehab, or even primary health. We did just have a posting here in Cape Breton for someone for a community health team, primary health team, as a recreation therapist. So I see things expanding, but so far not within cardiac rehab. But I will talk about what I think the role of a recreation therapist could be in that area, or recreation therapy professionals. And just a quick blurb for those of you who might not understand recreation therapy. It is kind of an unknown or misinterpreted profession often. But as recreation a therapist, we kind of look at our practice through two lenses or two avenues. One is that we know that having a fulfilling, independent, satisfying recreation and leisure lifestyle is just good for your overall health. It's not rocket science. We know that. We probably experience that ourselves, that the more connected we are to community, with people with like-minded interests, and the more active we are in those pursuits, the healthier we are. The other is using recreation and leisure as that modality for change or for rehabilitation. So that's what I'll kind of speak to here, is within recreation therapy, we want to use someone's interests, things that they find meaningful and valuable, to help them recover in whatever aspect that may be. So when we think about cardiac rehab, things that come to mind are physical activity, nutrition, stress management, and rec therapists have a part to play in all of that. So how can we work with the individual to find out what's meaningful to them in terms of physical activity? Of course, it's important, especially in this setting, to ensure that collaboration is there with the rest of the team to make sure that any of the health promoting activities that we want to try with the client aren't contraindicated in some way. So we would be looking at activities that would naturally lower blood pressure, things like Tai Chi, mindfulness, meditation, any aquatic programs, right? The hydrostatic pressure in water just makes venous blood flow to the heart much more easier, and the heart can work more effectively. So how can we match people up with some of these heart healthy activities that are of interest to them? Because we know that if people have an interest and a buy into those activities, they're more likely to continue with them. Someone brought up, talking about having a gym membership, and that's well and good. We know that, some doctors are now even prescribing gym memberships, but then there's all those things that come along with that: access to transportation and the anxiety that comes with going to the gym for the first time, or getting back to the gym after a cardiac event can be very stressful. So a recreation therapist will use motivational techniques and just support to get them back into those activities safely and meaningfully to them. And again, with a rec therapist, we'd be trained in looking for those kind of cues that there's something maybe happening, whether it's profuse sweating or cyanosis or fatigue or all that. So looking at kind of the activity tolerance when they're participating in those things. But again, working very closely with the medical team to ensure that we're not creating any contraindications. When we think of the activities themselves, there might be just some modifications that a recreation therapist can help with. And oftentimes my time in physical rehab, I work closely with the physio and the OT to look at those activities, making them safe, but also modifications and adaptations to them. So maybe the person's a big bowler now, but because of the point that they're in their recovery, maybe the weight of the bowling ball might be too heavy. So looking at some alternatives to that, just simple things, talking about energy conservation and how they can participate in the activities while still ensuring that they're conserving that energy and taking breaks when needed. A lot of recreation therapy is rooted in positive psychology. So when you look at the activities and making them meaningful and spending time in kind of the happiness that those activities enjoy or bring about, like Naj spoke about at the beginning, around that depression and anxiety, really using recreation and leisure to make people happier. It's as simple as that. Make people happier, feeling less stressed, more connected to their community. When we think of some of those other aspects of positive psychology around the, kindness boosters and empathy boosters, again, those activities or participating in them or being more mindful of those aspects of everyday activities can help with a person feeling better about themselves, having a better sense of self and identity, and just having more positive outlook on life, which again can reduce some of those things that come along with a cardiac event. Just check to see what else. Oh, and of course, when we think of I think recreation therapy has a big part to play in the prevention of cardiovascular disease overall. It would be wonderful if everybody from childhood up would have access to a recreation therapist to really ensure that they have great opportunities for recreation and leisure, again, that are rooted in their community, that are rooted with their cultural identity. So that's another thing that we would have to ensure that we look at. Are these activities appropriate to who they are, where they are in life, in the community in which they come from, and how they can participate in those things. So prevention, I think, is a big piece where recreation therapy can play. When we look at those contributing health diseases that would put someone at higher risk for heart disease, depression, anxiety, alcohol use, smoking cessation, looking at activities again to decrease those things, to be from a more preventative lens, is also really important. One new venture that is happening across the province, I'm sure some of you are aware of, are these mobility assistants that are within the hospital system. Here in Cape Breton, if you couldn't tell, that's where I'm speaking from. You can't hear the accent, but here in Cape Breton, we use a lot of the therapeutic recreation diploma students in those positions. Now, they could also be OT and PTA assistants as well. We just have the diploma program here. It's in which I teach. That's what I do. I used to be a recreation therapist, mental health and addictions, but now I'm an educator with NSCC. And the positive outcomes that they've seen from that program are really astounding. It's for folks that have come into the hospital for whatever reason. Many could be cardiac related, and to keep them mobile while they're in hospital, because we know there's a high incidence of, muscle atrophy and just immobility after people come into the hospital for whatever reason. So they've hired this team of mobility assistants working with the OT, the PT, the nurse, and a recreation therapist to create plans to motivate the client to get them up out of bed every day. So it might not be attending group programs, but it's very individualized to that person. And they've seen a lot of really great benefit. I can only speak to Cape Breton, but really great benefit with those mobility assistants to keep people active while in hospital receiving care for whatever it might be. But many it is cardiac events. Yeah, I think from my perspective, that because we don't have anybody who works in cardiac rehab, that's kind of my pitch, that it would be great to be able to refer to a recreation therapist as well, to look at that kind of whole well-being of the individual, their interests. How do you engage family into those things? If it's going to be, we want to have them more active and participating in exercise for the rest of their lives so they don't come back into hospital with similar instances. How do we get their family and their community involved as well to support that? If someone is coming with a lot of those contributing factors, they might be also included in their family, and friends might share some of those risk factors as well. So how can we promote that change to not only make that person more active and well in their whole life, but their family and their direct community as well. So I thank you all, and here's hoping that we'll see a recreation therapist position in cardiac rehab soon. Thank you.
Thank you so very much. Definitely grateful to everyone for sharing some of your perspectives. Paige had to run, one of the hazards of being a healthcare provider, right? But said that if anyone had any questions, you can contact me. I'll put my email in there and I can connect you to her. We've had a couple of questions that have come in. One was around, is spiritual care culturally inclusive? And then the other question that came to me was around recreation therapy, and how does recreation therapy deal with the fact that sometimes people are afraid to move, or or may not even know how to have fun because that's the stress that got them into the problem. So those are two of the questions that came up. Maybe we'll start with Kirsten, and then if anyone has any physical therapy, or from your perspective as well as a physical therapist, dealing with that fear to move is probably something that you deal with a lot too. So yes, Kirsten.
Sure. That's a wonderful question, and I thank you for it, Holly. Cultural inclusivity. I'm sure many of you have noticed that all of us come into work with a lot of underlying beliefs and values about how to be good to people. And we get them in various ways, but a good percentage of us have internalized them from some sort of community formation, which may be religious in nature, may not, may be something else, but they have a similar effect. So in spiritual care, a huge amount of our training and time is spent on learning how to stop yourself from assuming anything about anyone. Um, and also to become deeply aware of our own beliefs, values, and biases from our own training and belief systems. So we're not blank pieces of paper who have no beliefs. I'm an Anglican priest as well as a certified um, spiritual care specialist. So I have my Anglican hat, I have my spiritual care hat, I have my just plain human hat. And part of a spiritual care clinician's magic power is to be aware of all these hats and to keep them in sight when dealing with another person. So when we come to a person, we wait for the person to define themselves in terms of culture and belief. And I learned very quickly in my early career, I was Anglican and working in an Anglican environment, that you can't even make any assumptions about people who say they're from the same group because you're just wrong, because they all have different thoughts and feelings and beliefs and experiences. So we get very granular and we resist using labels, and we ask people, who are you? What do you need? Can I help you? Do you need someone else? And we follow direction of the patient and family. So I hope that that helps kind of define a little bit more what I said. And I also just want to acknowledge that, you know, we're all out there in healthcare doing the best we can for people. And I've seen nurses praying at the bedside of patients because that's the thing they know how to do, and they're offering it out of the humbleness of themselves and their own beliefs and values. And hopefully that, you know, even if they're doing it for someone who doesn't believe in prayer, usually people are pretty grateful that their healthcare staff are expressing care and concern. So I see it all over the place. It's a very complicated, tangled web when you get down into all of our beliefs and values, and then trying to categorize it into groups and labels. So we tend to be anti-label, very individually focused, and always asking the question, what does that mean to you to be an Anglican, or to be an atheist, or to be uncertain of anything, and get down into the basement level. So I hope that helps. And Holly, thank you for the question. It's a great one.
Thank you. And we will be talking more in August about how do we, as different professions, make assessments where we can advocate for each other or know when to make a referral. So, for example, one of the things that's really important is that if the nurse, for example, is feeling called to pray, they may be feeling called to pray because of their own beliefs, but it's possible that it could actually cause harm to the patient if the person didn't do a good assessment. Let's say I had experienced conversion therapy, I would be triggered by that experience. Or if I am of a non-Christian faith background, I might feel like I'm being proselytized, and that could cause me harm and cause me to feel unsafe. So it's important to make those, having a clinical provider, but actually oftentimes the clinical spiritual care provider is the one who will be, for example, advocating for religious diversity, which is a growing issue in our population more broadly, but also, for example, for Indigenous patients to be able to access Indigenous ways of knowing and being, and smudging or other things, which is a different issue.
Yes. And
So
Naj, you just made me think, just quickly, if the spiritual care clinician can kind of get on board there and see the whole train coming down the track, then they can care for the patient in an appropriate way and that nurse who feels she needs to pray because that's coming out of a different need. So we're kind of interfacing on both sides there.
Or the nurses stepping in, recognizing there's a spiritual need that has not been met because there hasn't been that comprehensive assessment. Oh, heart disease. Heart disease involves whole person care. Whole person care involves all the different disciplines being proactively integrated early to do a full assessment. The other question that was brought in was around how do we deal with the fear of movement after exercise, or even figuring out what kind of physical hobby or activity might look like. So we'll start with Dawn and then we'll go to Elizabeth.
Sure. I'm thinking back to my time working in mental health in Halifax at the Abbey Lane, and the folks that would be there receiving treatment for eating disorders often had compromised cardiac issues as well because of the nature of the disease. So when we're thinking about getting back into physical activity, it can be scary, especially after an event. But if you're at high risk of having that event. So I always like to, and this is speaking for myself, but I think a lot of rec therapists would follow the same way, is that we go in with no barriers first. So if you could do whatever you wanted to do, like what are your interests? Let's get that full picture first, and then be able to adapt for that. So in my experience at the Abbey, we'd make this plan, this big grandiose plan of all the things that they would like to do, where their fears are, and then we would actually sit with the doctor to go through those things. So I would be there to hear the doctor's recommendations or modifications. So that would be another support to the patient, because they could also get overwhelmed by all that information coming at them on what they can do and can't do. And then actually being that support person to not only motivate them to try, right? Go with them. We'll try. If it's just 2 minutes is all the activity you can handle, well, that's 2 minutes. We can build on that from that, and then being able to talk through that beforehand. Also looking at, some anxiety decreasing, stress management techniques prior to, especially if there's a lot of anxiety going into a certain setting or trying a certain activity, to be able to work with them through that, maybe even using some visualization of what that might look like leading up to the activity, the feelings that come along with that. So it's, in lots of ways, it's really important to have that interdisciplinary approach to this to ensure that the support is there for the client, but also that the recreation therapist, although trained in all the healthcare conditions, would be able to ask those pointed questions to the healthcare team. That this is where the patient is kind of having the most anxiety around. How can we brainstorm around that and then I can be the support person to help them carry those things out in the community, if that makes sense.
Thank you so much. Elizabeth, any last comments on your perspective about this question or anything else that might have come up?
I mean, I come from a very different perspective, and I have a lot of tools in my toolkit here at Cardiac Rehab, which is very great. Big part of it is education with our patients. Going over like the signs and symptoms they know to look out for, like when they know when they need to look for further help. Our nurses are always educating on things like as medications, like when to use your nitro spray, all those sorts of things as well. So really educating them on like, what is a normal thing to feel? When should you follow up with your doctor? And like, when should you be calling 911? Often as well, a lot of people come out of the hospital not knowing really what is going on in there. They don't quite understand the anatomy or the physiology or the procedure that was done. And, sometimes we have people come in and they had coronary artery disease and they put some stents in and there's nothing else left in there. And sometimes they had some stents put in, but maybe they still have some residual disease as well. And the other piece of that is, thankfully, most of our patients come in and they have stress testing done. So we really have a really good idea of from a cardiac perspective, if a patient's still getting any ischemia or reduced blood flow to the heart with exercise, which is another really great tool. And then they are on site for 12 weeks for our program. So some of our patients come in once a week and some of them come in twice a week. So building that confidence with exercise is a really big piece of that, as well as they're coming in every week to do that. So that part's really great as well. And I mean, yeah, there are patients that still have fear, and like trying to meet them where they're at and what their goals are, and trying to find things that they enjoy to kind of encourage that participation exercise is really important as well.
Thank you so very much. We had an awesome question that was posed, and it's actually going to be the October theme of our panel, is looking at decolonizing our care and unlearning assumptions and biases. But the question is, what has been your biggest unlearning thus far? If you wanted to think about that in terms of your different disciplines, I'm going to just take a second while you're thinking about that question, which is a big question. How do you distill it in just a few brief moments, because it's where we have run over. But I wanted to say, from a social work perspective, right? So in terms of thinking about some of these questions around fear of getting involved and being able to enter into some of these activities, obviously having access to transportation, funding, the childcare, having issues around justice issues, all of those different psychosocial structural determinants of health are going to impact a person's ability to follow through on some of their regimen adherence behaviors related to cardiac care. And I did have an opportunity when I worked prior to moving to this province. I worked with multiple hospitals. We had a Center for Healthy Living lifestyle medicine center, and it was based upon Dean Ornish, who is a doctor who has a 4-part method of healing heart disease. And his method is some gentle movement and exercise, some dietary changes, vegan, non-fat, organic food, social support, and mindfulness. Those were the 4 components that are evidence-based, that are proven effective. And in our healthy lifestyle centers, we had actually all of the different disciplines: social workers, spiritual care providers, recreation therapists, physical therapists, occupational therapists, nurses, all circulating in the gym. And we also had peer support specialists and community health navigators, and they were rounding on patients while they were walking, and checking on them. How are they doing? Peer support to manage addiction, because healthcare providers maybe don't have that lived experience that someone who has first voice experience can have, to build that readiness and be like, oh, I've been there, I've gone through this, and I've been on the other side. And community health navigators to help with other types of resources. What we found when we put patients with heart disease who were maybe waiting for a heart transplant, while they were waiting for the transplant to be available, the hospital that I worked for put patients in this program, and many of the patients no longer qualified for a heart transplant after engaging in this kind of care, because it actually reversed the heart disease and its markers. So this is where thinking about whole person care can actually save the system money, which is, of course, one goal, not the primary goal. It can reduce the burnout of healthcare providers, because the doctors and the nurses can be liberated to do their training, and other healthcare disciplines can step in to provide more comprehensive care, but also better care for the patient, and helping patients get back into the community. Because if they're depressed and anxious because of their heart attack, for example, then they are not necessarily able to engage in their communities as meaningfully. That might impact their return to work. It impacts everyone around them too. So very grateful to all of you for helping us expand our thinking around cardiac care and the role of collaborative care and quote unquote allied health professions. Last question, just to close us off, is the question on what has been your biggest unlearning? And it's going to be just a teaser answer, because we will in October have a chance to think more broadly around what does decolonizing our care look like. But obviously, even just our assumptions about what healing or medicine looks like, what different disciplines look like, let alone what do unique people all have as health needs in their wellness journey. What are your thoughts around unlearning? Kirsten, you've unmuted, so I'm going to think you want to go first.
It is a great question, and my mind was going all over the place. But just as a teaser, my first thoughts are my greatest unlearning involves my own bias that systems work incredibly functionally and to the benefit of all people. And I'm involved in a number of systems, and over the course of my career, just trying, and I'm talking not individuals, but policies, procedures, that kind of level, has not always been benevolent and healing. And that has been a profound frustration in my professional life. And the way it comes down to individuals, it's heartbreaking sometimes, even though my tradition, I come from a tradition that's founded on brokenness that then becomes wholeness. And I believe in that metaphor, and yet so many institutions, and let's face it, lots of us human beings cannot achieve this in this life. So I was thinking, the alternative is witnessing what can't be healed, not abandoning it. And then I thought, actually, when you stop trying to force, or through helpfulness or goodwill or intention, healing and wholeness, it actually becomes a moment of great power that then goes off with the patient that you're working with, and can become completely life-changing, to just be present, to witness and say, yes, you're right, this is awful, and this is where you are, and you don't have to move, and you are still cared for. That has been a very profound learning. Those are my initial thoughts. Thank you.
I think for me, it's that there's a much larger gap between theory and practice than I had ever imagined when I was in school or in the beginning of my career. And people of a certain age, that gap gets further and further away because of the systems in which our initial practices and theories were built. So it's exciting to see. I'm excited for October, and it's exciting to see the changes that are happening in all health disciplines, to move away from that kind of colonized way of looking at healthcare and healthcare practices.
Yeah, and I think for me, we always look at our patients and we think a lot about the modifiable risk factors for cardiac disease and unmodifiable risk factors. But when you think about things like ethnicity and culture, they really intersect between the two. Um, we often think about those non-modifiable risk factors as things like genetics, for example, but it's so much more than that. And I think I'm still learning a lot about, um, like, we've had patients from many different backgrounds come through, and whether that be, culturally what they eat, or, you know, maybe the roles that they take on, as a member of their society, for example. There's so many different things that interact there, and it's not so, black and white, I think.
Thank you. And I think for me, one of my biggest unlearning that is the role of the clinician's own bias or perception and lived experience. So because my lived experience has taught me X, I have to make sure to be aware that that might or might not be true for other people. And sometimes when I think it is, it's not. And sometimes when I think it's not, it is. And so that humility and recognizing and appreciating the role of the assessment. When I was in social work school, or whatever, getting my master's degree, I remember we spent so much time on assessments, and we would be like, well, what about the treatment? Like, why are we spending so much time on the assessment? But unless we fully understand, then everything else is missing. And perhaps that is actually the issue with our healthcare system and its current struggles, because it is only biomedical, and it doesn't have the psychosocial, spiritual, structural determinants of health that are integrated into the patient care from beginning all the way through even past discharge, understanding that what happens in the hospital is part of a much larger whole, and understanding the intergenerational and structural factors, and how do we intervene in ways that promote the health of every single person, which partially involves rethinking even just the way medicine exists right now, which so much of the research is done in ways that are not reflective of the actual patient populations we have. So there's so much unlearning, and we hope that everyone will join us for our next luncheon, which will be in June, and then we will have another panel in August and another panel in October. And this is just the beginning of, certainly for the Nova Scotia College of Social Workers, thinking about social work and healthcare settings more broadly. What does that look like? And then how can we continue to partner with other professions to reduce silos and improve patient outcomes for everyone. So grateful to you all for joining us today, for sharing of your wisdom and experiences and perspectives, to the awesome conversation in the chat from everyone. And if you're joining us afterwards on YouTube, thank you so much for watching us, and hope that you watch the rest of our series and that you have a wonderful day. Thank you, everyone.